Hi, this is Elliot Fishman, and welcome back to part 2 of our newest look at hepatic masses. And last time we left off talking about, or beginning to talk about, cystic lesions. And then we're going to talk about all benign hepatic tumors, hemangiomas, FNH, and hepatic adenomas, which kind of are on that cusp between benign and malignant. Well, when you talk about cystic hepatic lesions, what do you talk about? Well, you could divide them into categories. Let's say developmental, hepatic cysts, biliary hamartomas, polycystic liver disease, Crowley's disease, and the unusual ciliated hepatic foregut duplication cyst, which I've seen about 2 times. We can talk about neoplastic lesions, biliary cystadenoma, cystadenocarcinoma. Remember, in the old days, we thought we could separate the two. Now we know it's a spectrum, so we just need to recognize it, and it'll be resected. We talk about cystic liver mets, classic from ovarian cancer and GIST tumors, as well as cystic hepatocellular carcinoma. We talk about inflammatory cystic lesions, whether it's a pyogenic liver abscess, an amoebic liver abscess, typically right lobe, the classic Hydatid cyst with multiple cysts in up to, let's say, 60% or so with calcification. And we talk about fungal microabscesses, which are small, cystic, often also involve the spleen and or kidney, but are typically seen in immunosuppressed patients. Again, history is going to help us. We spoke about that in one of the early slides in part 1. And then there are trauma-related cystic lesions, hematomas, myelomas, seromas. Trauma can be like an MVA, can be a stab wound, or can be post-operative trauma. So let's talk about hepatic cysts first. They occur in about 10% of patients. Water density, sharp margins, can be single or can be multiple. Most patients who have hepatic cysts, they're small. They're a centimeter or less in size. The better contrast you give, particularly in venous, the more cysts you're going to see. And as I mentioned previously, one of the challenges we face is with little tiny lesions that are probably cysts. How do you know it's not a metastasis? Again, cysts, water density, no enhancement, sharp borders. Cysts can be larger. Here's a larger one in both the left and right lobe of the liver. Very well defined, no enhancement. Cysts typically do not calcify. If you see a cystic lesion with rim calcification, most likely it's going to be an old hematoma. We will look at hydatid cysts. They also can be cystic with rim calcification, but usually they're multilocular cysts in that scenario. Hepatic cysts can have mass effect. When they get large enough, they can displace vessels, as in this case, but they do not cause any irregularity of vessels. On the arterial side, there's no neovascularity, and typically, even when they're large, hepatic cysts do not cause problems for the hepatic veins or portal vein any more than simply displacing the vessels. Now, one of the things when you look at this hepatic cyst is you look medially and you say, is there some enhancement of the medial wall? Well, what you're really looking at here, typically shown on the arterial phase imaging, is that the large cyst has mass effect on the normal liver. And so what you're seeing is not the cyst wall enhancing, but the normal liver being compressed. You can see that nicely when you look at the MIP image, where you can see the hepatic artery is splayed by the large cystic lesion. So you need to be careful not to overcall this. Polycystic liver disease, half the patients also have polycystic kidney disease, half do not. Multiple cysts can vary in size from small cysts to medium cysts to large cysts or any combination. Here's a patient with a large cyst in the right lobe of the liver and multiple smaller cysts in the left lobe of the liver. Again, there are a range of appearances. Patients with polycystic liver disease will often have a large liver. They typically do not have dilated ducts, and as I mentioned, if you're uncertain, look at the kidneys, and half the time the kidneys will give you the answer. Same patient in coronal view, polycystic liver disease, but in this case you can see the kidneys look normal. And again, large cysts, 10 centimeters or greater, multiple 4 or 5 centimeter cysts, and multiple 1 centimeter or less cysts. So it's not uncommon in a single patient to have the spectrum of variable sizes. Now, if hepatic cysts get large enough and they compress adjacent vessels, particularly the IVC, you can see perfusion changes as you do in this case. We typically like to say that you don't see perfusion changes from benign lesions like hepatic cysts, but the fact is anything that gets large enough and gives you mass effect and compresses critical vessels can give you perfusion changes. Now, things that look like simple cysts, biliomas, here it's easy because you can see the surgical clips. So biliomas are not uncommon in patients with hepatic surgery. You can have biliomas or seromas in patients who've had trauma as well. You also can have hematomas, and when they're more chronic, they're typically water density, hard to distinguish from biliomas, but again, well-defined, sharply marginated. The one thing you would say about this case, it's a benign lesion, and noticing the clips present and then looking at the patient's history. Again, history can be helpful. You know this is simply going to be a bilioma, which typically will resolve over time, or you'll simply leave it alone, or if the patient is symptomatic, you would actually drain it. Now, sometimes cases aren't that simple. Here's a low-density lesion centrally in the liver on arterial phase imaging. When you look at it, it first looks like a cyst because it's lower density, but it is low density, but it's not cystic. It's not as dense as the normal parenchyma, but it's still denser than a cyst. It's well defined and sharply marginated as you go to the venous phase imaging. It appears to push the hepatic veins a bit, but it's very well defined and it's low density. You can see it again toward the dome of the liver. And as you do the 3D mapping, portal vein, the hepatic veins, there's no abnormal vascularity, but this lesion has mass effect and it's low density. Could it be a cyst that bled? I guess that's a possibility. That may explain the higher density. Here's a cinematic rendering. It's kind of that appearance of a cystic lesion, but you could see it kind of looks like there's scallops along the lesion. There's some scalloping. You're not going to see scalloping on a simple benign cyst, so that becomes a little bit more problematic to me. What are we dealing with? I don't know. Low density lesion, well defined, doesn't look like a cyst. The patient wasn't febrile. It's not going to be an abscess. This was eventually biopsied and then removed. It was hepatic adenoma. I show this case because lesions sometimes don't follow the rule book. I would never look at this lesion and say hepatic adenoma. Where's the vascularity? Where's the enhancement? Where's the prominent vessels? Why does it look so low density across all phases? Well, this was surgically proven to be a hepatic adenoma. Now, I mentioned you could have cystic metastasis. The difference is when you look at this image on the late phase, you can see the lesion is cystic, but the rim of the lesion is irregular. And if you look at the arterial phase, you would see the thickening of the rim and the prominent neovascularity. That's going to be a tumor. You can argue, could this be a primary hepatic tumor like a cystic hepatoma? It's more likely metastasis. This was a spindle cell sarcoma. I mentioned that the typical mets that go to the liver that are cystic, classic ovarian cancer, as well as GIST tumors, whether they're from stomach, small bowel, or colon. Also, melanoma can be very cystic. I love this case because look at the neovascularity. Again, one thing from a technical perspective I find helpful is looking at lesions with MIP imaging. With MIP imaging, it's very nicely to show the neovascularity and the abnormal vascularity. and in this case, on later phase imaging, the really irregular and thickened rim of this complex cystic hepatic tumor. Now, what about this case? There's a lesion in the left lobe of the liver with mass effect. From the axial images arterial phase to the images with cinematic rendering, you look as you go back and you notice this lesion has multiple septations. It's cystic and maybe solid. What could this be? It's not going to be just a simple cyst. This looks like a cystic tumor. Remember I mentioned that cystic tumors can be sarcomas. They can be GIST tumors like here, where there's wall thickening, enhancement in the lesion, mass effect, some vascularity. Well, the same thing with this lesion. There's cystic changes and solid components present. Could this be metastasis from a GIST tumor? I guess it could be. Could this be a hepatoma? I guess it could be. This kind of looks like a primary liver lesion that's both cystic and solid. I don't see too much else in the abdomen except for a cystic lesion in the right lower quadrant, which could be coming from the appendix. And again, more images of the cystic lesion in the liver. This was a very unusual case. My differential would have focused on a malignancy, possibly hepatoma, hepatic adenoma perhaps, but something else to think about is cholangiocarcinoma. When we say cholangiocarcinomas, we typically think about dilated intrahepatic ducts, but cholangiocarcinomas can be solid infiltrating lesions. They can cause duct dilatation. One way of distinguishing a cystic tumor or even a non-cystic cholangiocarcinoma is they often have duct dilatation. This case didn't, but hepatomas typically do not have duct dilatation, and cholangiocarcinomas do. What else can we think about? Well, what about this case? This patient was febrile, and yes, febrile, I'm always thinking abscess, but I could be thinking about malignancy as a presentation, particularly something like lymphoma. But if I look at this case, there are multiple lesions in the right lobe. The borders aren't that sharp. They're not perfectly cystic. And as you go from arterial to venous, the lesions are multiple and in fact tend to be a little better seen on the venous phase imaging. There's some thickening around the wall, and when I start seeing a complex group of cystic lesions, better seen venous than arterial, yes, I could have considered the things I spoke about before, like a cystic cholangiocarcinoma or other cystic tumors, but in a patient who's febrile, I got to be thinking, and the more I look at this, there's more lesions present. Yes, could I be thinking about malignancy? But, it's possible, right? It could be metastasis. But so many lesions clustered together almost looks like a cloverleaf sign, which is a sign you talk about in patients with liver abscesses. As you scanned into the patient's pelvis, the patient had diverticulitis, and this was a liver abscess, more common in the right lobe, from acute diverticulitis. You can see liver abscesses from diverticulitis. You can see them from appendicitis. You can see them from Crohn's disease. So it's something to think about. This patient also was HIV positive, so infection would be very close to the top of your list, even before you saw the colon. What about this case? Cystic lesion, right lobe of liver. Right lobe of liver, you can have an abscess just like the prior case, but amoebic abscesses are commonly cystic. Perfusion changes are common. This is not a simple cyst. Look at all of those perfusion changes. Look at the right pleural effusion. This was a liver abscess, and this ended up being an amoebic abscess. In the postoperative patient, this ring-like appearance with multiple lesions is classic for a liver abscess. This ring appearance is very good for abscess. And again, in the postoperative patient, if you do not have any liver lesions pre-op, if something develops post-op within a month or so, surely within a few weeks, it's going to be a post-op abscess, which is often multiple and more common in the right lobe. And of course, when you have air bubbles, it makes it very simple. When you look for air bubbles in an abscess, it's probably about 10% of abscesses. So if you need to see air bubbles in an abscess, that was something that was spoken about 40 years ago, you're going to miss 90% of abscesses. So you better start calling them without the presence of air. Now, there are unusual infections. Here's a great case. Complex cystic mass in the liver with multiple septations that are seen kind of around the edge of the lesion. I don't see any calcification. This was a veterinarian from Africa who had fever. The history of vet and from Africa, you got to think about what's endemic in that region. What is a large complex cystic lesion with multiple septations, which represent multiple daughter cystic lesions, well defined. I don't see anything extrahepatic, beautifully shown on the cinematic rendering here and here as well. This is a classic case, and by far the best case I have of Hydatid disease, both from a cinematic perspective and a non-cinematic perspective. Just very classic. Take a look at those images. And it was such a good case, it was published in Radiology about a year ago. Just a really nice example. Also showing you some of the value of cinematic rendering and looking at cystic lesions. Now, in addition to infection, we spoke about cystic lesions and the possibility of malignancy. Biliary cystadenoma and cystadenocarcinoma, one possibility. Cystic hepatoma, cystic metastasis, I showed you a few examples. Mesenchymal hamartoma and inflammatory myoblastic tumors can be cystic, but they're exceedingly rare. Let's talk a little bit about biliary cystadenomas and carcinomas. They're usually middle-aged female. We used to try to distinguish by looking for nodules, what was benign, what was malignant, but biliary cystadenomas can transform into cystadenocarcinomas, and so all are treated aggressively and resected. They're large, solitary, multilocular cystic lesions, often with well-defined borders and prominent septi. You may see enhancement or calcification in the cyst wall. This is a biliary cystadenoma. In the differential diagnosis, when I look at this case, perhaps based on the cases a few moments ago, the first thing I would have said was, could this be Hydatid disease? Clinical history and lab values can help you, but this was a biliary cystadenoma. Again, mucinous tumor of the biliary tree and liver. There's cystic neoplasms, again, unilocular or multilocular. Very, very nice appearance. And they can be large, 3 to 40 centimeters. There are no specific imaging features that permit reliable differentiation between cystadenoma and cystadenocarcinoma, which is why they're all resected. And again, I mentioned that it's felt that cystadenomas can become over time cystadenocarcinomas, so there's little room for argument. And again, the septa may enhance and occasionally may calcify. From a perspective of demographics, more common in women aged 30 to 50, so it's a little bit younger than some of the cystic metastases, so it's something at least you should think about. And I think it's pretty easy to distinguish them from simple cysts of the liver. So again, very important, and the pathology would be mucin-secreting columnar or cuboidal epithelium. So very, very, very important. In this article by Kim, where they look at distinguishing cystic neoplasms and simple cysts, they made the point that upstream duct dilatation, lesions in the left lobe, fewer than 3 coexistent cysts, and THAD defects, the perfusion changes, were suggestive for differentiating biliary cystic neoplasms from hepatic cysts. And we agree with that statement as well. So again, those 4 features become very important. You just do not see dilated intrahepatic ducts from a simple cyst even when they're large. So when you see ducts, you have to worry about malignancy. I mentioned perfusion changes are less common with cysts. They can occur, but indeed it's rare. And left lobe is more common for these biliary cystadenomas, which are like the cases I've shown you today. Hepatic cysts can be anywhere in the liver. They can be left lobe, but usually the more common right lobe, and they are in multiple locations. So let me finish with a couple examples. Nice biliary cystadenoma, complex cystic lesion with multiple septations, no intrahepatic duct dilatation. Again, differential diagnosis could be a biliary cystadenoma, which this is, or it could be a hydatid cyst. That would be a possibility. You would not be calling this a simple cyst. It doesn't have the look of a cystic hepatoma or metastasis. There's no thickening or enhancement around the edge of the lesion. Here's another case which looks for all the world almost just like a cyst or even a cystic lesion near the liver. This was a biliary cyst adenocarcinoma. It's in the liver. It can be very challenging. There's some nodularity in the wall, which is nicely seen on these volume rendered images, but you can see the problem. It's not an easy call. You might have favored a cystadenoma, but this was a cyst adenocarcinoma when all was said and done. You could talk about complex cystic lesions like this, multiple cysts, dystrophic calcifications. That appearance to me is malignancy. I could think about hepatoma. I could think about a sarcoma of the liver. Those are possibilities. I could think about a biliary cystadenoma. There's compression of the portal vein, but no invasion of the portal vein. Multiple images showing very sharp margins to the lesion. It is right lobe, not left lobe, but still a biliary cystadenoma would be a good thought, though there are multiple cysts present, and this was a cyst adenocarcinoma. So you got the right answer. What about this case? This was a younger patient, 12 years old, coming off the liver, a large cystic lesion, some increased vascularity, really necrotic. I guess I could think about a cyst adenocarcinoma, though that doesn't occur in 12-year-olds. We mentioned it's age 30 to 50, but occasionally you could be fooled. Could this be a hepatoma? Look at the neovascularity present. The neovascularity is not something with biliary cystadenomas or cyst adenocarcinomas to this degree. It could be hepatoma. It could be because the patient's young, hepatoblastoma. Those are often very vascular, and that would be a good possibility. But this ended up being biopsied. Eventually, it was in part resected and was an embryonal sarcoma. So sarcomas in the liver, I typically don't mention them because they're so rare. But in a child, you got to think about hepatoblastoma. You got to think about metastasis. You got to think about various sarcomas of the liver. Now, we've covered a lot of cystic lesions, and the next thing we're going to speak about is hepatic hemangiomas. Hepatic hemangiomas are an important diagnosis because often they can be confused or suspected to be malignant, particularly in an oncology patient. But before we start talking about hemangiomas, let's take a 5-minute break and see you in a few minutes. Bye, guys. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.